Hey guys, welcome to our lecture about induction drugs. Hope you're enjoying all of our lectures so far, and this is a new and exciting chapter of induction drugs. Induction of anesthesia. Induction of anesthesia is the critical phase where we transition a patient from an awake, conscious state to an unconscious state suitable for surgery. This process requires careful planning, drug selection, and anticipation of physiologic responses. A smooth and controlled induction sets the tone for the entire anesthetic and directly impacts patient safety and outcomes. Why does induction matter? Induction is often the most physiologically unstable period of anesthesia. During this time, patients are at risk for hypotension, hypoxia, and loss of airway control. A well-executed induction minimizes these risks and allows for a smooth transition into maintenance anesthesia. What is this induction sequence, you may say? Induction can be thought of as a controlled descent from wakefulness into unconsciousness safely. The patient progresses from being awake to sedated to hypnotized and finally to a state of surgical anesthesia. Our goal is to guide this progression in a controlled and predictable way, all while maintaining stability. You may ask yourself, what neurotransmitters are involved in induction? Most induction agents work by changing the neurotransmitters in the central nervous system. Propofol and etomidate enhance GABA, which slows brain activity. Ketamine blocks NMDA receptors, which prevents excitation. This is why ketamine creates a dissociative state instead of typical sedation. Clinical decision making. There is no one single induction drug that is appropriate for every single patient. Anesthesia providers must evaluate the patient's hemodynamic status, comorbidities, and surgical context. The selection of induction agent should always be tailored to the individual patient. Propofol. You've heard of that before. Let's go over that. Propofol is the most commonly used induction agent in modern anesthesia practice. It produces rapid onset of unconsciousness and allows for a smooth and predictable recovery. This makes it ideal for many routine surgical procedures. Let's go over the physiology. You might ask yourself, why is this so important? Propofol enhances GABA activity, leading to decreased neuronal firing and central nervous system depression. It decreases cerebral metabolic rate and intracranial pressure. However, it can also cause sometimes severe vasodilation and severe decreased cardiac output, which can result in severe hypotension. Propofol clinical considerations. Propofol causes significant respiratory depression and may lead to apnea, especially when given rapidly and in large doses. For this reason, airway management must always be anticipated prior to administration. Dose adjustments are required in elderly, hypovolemic, or unstable patients. Let's go on to number 2, etomidate. Let's go over etomidate. Etomidate is an induction agent known for its excellent hemodynamic stability. It produces unconsciousness with minimal impact on blood pressure and or cardiac function. This makes it especially useful in critically ill patients. Let's go over the physiology of etomidate. Etomidate enhances GABA activity similar to propofol, but does not depress significantly the myocardial function, so it's cardioprotective. It maintains cardiac output and blood pressure even in unstable patients. It also reduces intracranial pressure, making it useful in neuro cases. Something must be up with etomidate. What are the limitations? A major limitation of etomidate is the suppression of adrenal function. It inhibits the enzyme 11-beta hydroxylase, which is necessary for cortisol synthesis. This effect can impair the stress response, particularly in critically ill patients. So what's next? Ketamine. Let's go over ketamine. Ketamine is a unique induction agent that produces dissociative anesthesia. It works by blocking NMDA receptors and disrupting excitatory signaling in the brain. Patients may appear awake, but are not aware of their surroundings. Hence, it's dissociative. What's next? Physiology. Let's go over the physiology of ketamine. Ketamine stimulates the sympathetic nervous system, leading to increased heart rate and blood pressure. It preserves the respiratory drive and provides bronchodilation. These properties make it particularly useful in trauma and patients with reactive airway disease. Considerations for ketamine. Ketamine can cause emergence reactions such as hallucinations and agitation. These effects can be reduced with the use of benzodiazepines, like Versed. It should be used cautiously in patients with severe hypertension or certain cardiac conditions. Let's put it all together. When selecting induction agent, always consider the patient's physiology first. Propofol is ideal for stable patients, etomidate for unstable patients, and ketamine for hypotensive or bronchospastic patients. Your goal is to match the drug to the patient to ensure a safe and effective induction. So in conclusion, induction is a critical phase that requires knowledge, preparation, and clinical judgment. A smooth induction leads to better patient outcomes and easier anesthetic management. As a future CRNA, your role is to engineer a safe transition into anesthesia for every patient and out of anesthesia into recovery. Thank you for watching this video. Stay tuned for the next one.